Okay, we are live. Good luck.
Okay.
I think we're live, Dr. Dunn. People are joining. Let's just give it about 30 seconds and then there we go. Good evening, everyone, and welcome to tonight's webinar. Welcome to the Menopause webinar with Dr. Dunn. I am your host, Boitumelo Sebambo. Tonight's webinar is brought to you by Salome Menopause, which is a combination herbal medicinal product for the relief of menopause complaints, such as hot flushes, profuse sweating, and low moods rather. Before we start, let me introduce our expert, Dr. Zandile Dunn. Evening, Dr. Zandile, how are you doing?
Evening, Boitumelo, and evening to all our guests. I'm doing very well, thank you. I hope everyone is too, and ready to absorb some valuable information this evening on menopause.
I think everybody is. We got an overwhelming response and a set of questions. I thought maybe because tonight's webinar is on menopause, let's start with the basics, Doc. What is menopause? What brings it on? What is happening? Let's start there and then take the conversation from there.
All right, so the basics of menopause is that it's the end of the reproductive life of a woman. And this happens with everyone. So we are born with a finite number of eggs, and every month we release them through our cycle called the menstrual cycle. And by the time we reach around the ages of 45 to 55, there's the end of that cycle. So that's the basic ages, and it's preceded by a period called perimenopause. And this is the time whereby one could get symptoms that Boitumelo has already alluded to, and irregular menses, as well as the cessation of menses. So this is defined by 12 months of menstruation that has now stopped. So if you have not had your menses for 12 months and you are around that age, then this is defined as menopause. So the perimenopausal period, women still do experience. So you'll have a few months without your menstrual cycle, or heavy bleeding, and then symptoms that, you know, the hallmark are hot flushes and vaginal and urinary symptoms. And then, of course, you know, some women experience cognitive dysfunction and, you know, memory loss and a reduced sexual drive and all of that. So we'll dive into, you know, a lot more within the webinar.
We definitely have to dive in more. I mean, you've mentioned some symptoms I've never, you know, heard about. I think menopause is always just associated with hot flushes, and cognitive symptoms are such a new thing, particularly post-COVID. I think that's become quite topical. So I think we'll revisit that discussion around cognitive. One of the questions we received, and I think maybe it's because some people feel they're experiencing early menopause, is really questions around early menopause. Most women are asking, what is the typical age? So you've said 45, 55, but what are the chances of early menopause? And that's what we're seeing, a lot of questions around people who are possibly under 40, under 45, asking that question. And perhaps it's because they were experiencing those symptoms.
So there are different types of menopause. The first one is the one that we've just mentioned, that natural cycle. But some women do experience menopause quite early, from the ages of like younger than 40. So those women, we call it premature ovarian failure. And it's a hormonal thing that happens. So where the hormones in your brain are not talking to the hormones that are supposed to be made by your ovaries. And then there are some women that have had surgery. So when you have your ovaries removed, that is called surgical menopause. Then you have women that have been on chemotherapy, for example, radiation therapy, and for cancer or anything. Then you have menopause as well, because that causes like destruction of the ovaries. And so yes, so there can be cessation of menses at a younger age. And although, reproductive years or the reproductive ability, to start to decline by 41. I mean, we've seen women falling pregnant at later stages, like 44, 45, that were spontaneous. But otherwise, yeah, you definitely can get younger women that experience menopause.
I think one of the things I didn't do when we started, Dr. Dunn, is just to say to everybody, if there's any questions they'd like to ask us on what we're talking about, if people want to have clarity, please just post some questions on the webinar. I'll get to what I can get to, and any questions we don't get to, what we usually do is a week after the webinar. So we post those questions on our website, www.salome_range.co.za, and you can go back and revisit. We've got an FAQ related to the webinar. But if there's anything that Dr. Dunn is saying and you just want a little bit of clarity, please just post questions and we'll try to get to as many as possible. So one of the things that most women are interested in, and maybe it's because women are having kids later, is we've received some questions where people are asking, can they still fall pregnant when they're perimenopausal? Can they fall pregnant when they've got menopause? Yeah, Doc.
So in menopause, no, by true definition, you are not ovulating anymore. There are no more eggs to release, because pregnancy happens when your eggs release what we call an oocyte that can meet a sperm and make a baby. So by true definition of menopause, you cannot fall pregnant. But in the perimenopausal period, yes, definitely. And that's why it's always suggested that women should stay on their contraceptives until they are sure that they're in menopause. So in other words, you've had no periods for 12 months and there is no other reason. So no other reason will then refer to the women that go through the menopause in the younger ages. So yes, definitely, it's very rare because, like I said, the reproductive chances are really, they get less and less, once we reach the age of 41. But it can definitely still happen. Yeah.
Thanks for answering that, because my next questions was going to be, when can you actually stop birth control? You're perimenopausal / menopausal. So it's obviously then when a doctor has confirmed that you are menopausal, but during perimenopause, continue to stay on birth control. Yeah. So one of the other things is, somebody was saying to us, and maybe this is where your medical brain comes in, is somebody saying, one, what are the treatments for menopause? And somebody else is asking, are there non-medical options? And I think it's because they're saying, one of the things is HRT safe? So I think let's get into treatments for menopause.
All right. So there's definitely treatments for menopause. There's hormonal treatments, there's non-hormonal treatments, and then there's symptom-directed treatment as well. So a lot of women, have heard of hormonal replacement therapy, and some women, certainly maybe women in their 50s, 60s, 70s, would have heard of, hormonal treatment studies and all of that, and having been deterred by, what they've heard about the side effects. So hormonal treatment includes estrogen, that's the main hormone that women have, as well as progesterone. So for women with uteruses, if they are on hormonal treatment, it must be combined, because if you're taking estrogen only, that can cause your lining to thicken and put you at risk for endometrial cancer. That is the lining of the womb that can, if it it's unopposed, we call it, if you have unopposed estrogen. So the progesterone works on thinning that line. You need to have two. But for women without uteruses, in other words, that have had what we call a hysterectomy or removal of the womb, if they're having replacement, then it's estrogen only. Now, there's lots of preparations for it. Like I said, we can have directed treatments, so gels, creams, and vaginal inserts bypass the system, okay? So that works very well for vaginal dryness and those symptoms, vaginal dryness or dryness on the vulva, or where you just put the insert or the gel, insert that into your vagina, and that can relieve vaginal dryness and improve your urinary symptoms as well, because some women find themselves that they, pain on urination, and improves sex as well, because they can get pain during sex. And then there's obviously the oral tablets, okay? So then those ones, they work, it's like similar to the oral contraceptive pill, where you have a combined preparation. Then you take that every day. So there's different preparations, cyclical or continuous. Cyclical has proven to be better, but some women, they don't prefer this bleeding, because if it's cyclical, then you still have, the bleeding, but the cyclical tends to be better. And then there's patches, there's sprays. So there are a lot of different preparations of, but the main hormones are estrogen and progesterone. So some of the treatments, we call them serotonin, like a serotonin, like the antidepressants. So there's paroxetine that works very well for hot flashes, and some high blood pressure medication also work very well for hot flashes, like clonidine. And these would generally be chosen if a woman has a risk of having the side effects that hormone replacement treatment can have, like clots in the leg or anywhere in the body. And then women that are at risk for breast cancer, and women that are at risk for heart disease, because unfortunately, as with all medication, there are side effects. So your patient selection is very important as to, who you give these. And then the non-hormonal, okay, we've touched on. And then there's also things like phytoestrogens, like soy supplements and all of that, because they are, similar to the estrogens.
Yeah.
Mm-hmm.
I don't know if everybody's following all these big medical terms. So for everybody else, we will put this webinar up on the website, because I think some of them I will forget. And I am 40, so I'm quite keen to listen attentively on just some of these things. But you've covered a couple of symptoms, right? You've covered vaginal dryness. You've covered urinary symptoms, and then you touched a bit when we started on cognitive issues. Let's just go through an exhaustive list, if we can call it that, of what the symptoms are, because people are saying, somebody on the live is saying, I'm having night sweats more than I'm having hot flashes. Somebody else earlier mentioned that they've got their libido has reduced, and somebody else actually said their sex drive has increased. So some of these are contradictory. So I think let's just go through what the symptoms could be, through perimenopause and menopause.
Okay. So the main symptoms are the ones that we've mentioned. So the hot flashes, urinary symptoms like burning, vaginal dryness, hair loss and thinning, and the abdominal girth, because your muscles relax, the muscles in the on the abdomen, like that six pack, that can relax, and women get reduced muscle mass, and then the ratio changes to be similar to men. If you've noticed, men gain more weight around their waistline versus everywhere else in the body. So once women reach menopause, then they'll find that the abdominal girth, becomes, a problematic area, sometimes drooping breasts, and sleep deprivation, fatigue. And then there are other more serious, like fractures, because estrogen is good for bone health. So for women that are at risk for fractures, they may find that, they get fractures. And then, I think it could be lots more, but at this point, yeah.
On the live, there's actually a question which I think relates. It's a question. It's not a comment that relates to what you've just said. And she says, I'm 47, done removal of the womb and a hysterectomy. Recently diagnosed with osteoporosis in the hip joints. I'm forever in pain. Are these two related? And now that I'm just listening to you talking around estrogen, I think probably this is, where this question comes from.
Yes. So it's been shown actually that even if one has, surgery of the pelvic organs, so the hysterectomy and removal of the tubes, because, you've got blood supply that is interconnected. So all the pelvic organs have blood supply that is interconnected. So those women tend to go into menopause earlier, even if their ovaries have been left inside. So it's important actually, to discuss, but your doctor would usually let you know what was done in the surgery. And if your ovaries have been removed, then you definitely go into menopause. This may definitely does contribute to the lower bone mass. So your estrogen contributes into building that whole process that helps you build the bone mass. So that may be, one of the reasons.
We're receiving a lot of questions, Dr. Dunn, around treatment. Around treatment, and so I'll get into it. So a lot of people were saying that their sex drive has decreased. How do they, deal with that particular symptom, and how do they bring it back, really?
Yeah, so I mean, it's a multi-pronged, problem, issue, right? So then there are many things that can cause a decreased sex drive. So obviously menopause, because, responsible hormones have now declined, but it's important to look at everything, okay? So there are physical symptoms, there are psychological symptoms, and then there's also relationship issues, okay? So in the physicals, those ones that we've mentioned, the body image also plays a role, because if your body's changing, you're not happy. And then if you're not in the mood, say you are, feeling a little bit irritable, that can also bring that about. If you've had surgery, if you're frail, and, it's important to recognize that with aging, we have a lot of chronic illnesses that also come about. So illnesses like hypertension or high blood pressure, diabetes is a big one. And, that definitely contributes to low sex drive. So it's important to rule out any physical ailments that a person has. And then psychologically, I mean, if you are, not well, not in a good mental state, depression, anxiety, all of those things contribute, because most people would be on antidepressants, which also reduce sex drive. And then, so you must, be aware and also inform your doctor about other medications that you've been on. And then psychologically and relationship issues, if you are not in a good space, obviously, with your partner, and then you're not communicating, that also plays a role. So of course, part of the treatment then becomes, this multidisciplinary. So your doctor will ask you all kinds of questions that we've alluded to, check which medications that you're on, and then do an exam, because the other main thing is that during menopause, the women get painful or experience painful sex as well, because it's dry. So it may tear or it just be unpleasant, uncomfortable. And so because they know that psychologically, then they don't want to engage in all of that. But certainly, yes, there are people that have lack of interest. So if it concerns you that I'm not interested, not even in self-pleasure, I'm not interested in even in fantasies, I don't think about sex, I don't imagine it, that's definitely one of the signs that you have, a low sex drive. And so when it comes to the treatment thereof, we look at all of these things. So it's couples therapy. So where they look both at you and your partner's physical state, and then counseling. But yes, there are, drugs I've only seen in the U. I haven't myself at any stage prescribed. And so there are, specialists that deal in sexual counseling or sexual, sexual therapy, in every form. And so there's, estrogen related antagonists, agonists, drugs. Testosterone is not suggested. It is off-label, so it's not approved for like these problems, because the side effects, women get hair, voice changes, body changes, and all of that. So hormone replacement therapy can definitely work, because you increase, or make more estrogen available. And so once the symptoms that are there, like say, for instance, you have vaginal dryness, then you can, it can improve that. And then lubricants are also important. So women should use water-based lubricants versus the oil-based. And then the estrogen gels and creams that can make those symptoms better and boost a little bit of hormone in your body.
It sounds like a new dynamic in what could possibly be very established relationships. I think it's quite complex, and perhaps this is why you're even suggesting therapy and maybe couple therapy, because you're obviously bringing something that wasn't in the relationship. If we as women don't know as much, so I'm assuming particularly those who are in relationships with men, they know even less than we do. So just that education would be quite different around that. I think, one of the questions is anxiety a symptom of menopause? And from what you're saying, it possibly is, because it's just a lot of change in the body, but also just the side effects of the treatments would bring on these kind of things.
And I mean, change that, we may not necessarily understand, or change that is quite frustrating to some women, because why should I accept it, just because somebody else went through it? Because that's exactly what happens with a lot of women. They've seen their aunts and mothers go through it. And so, they think it's normal, but, these are things and symptoms that can be alleviated.
Hot flushes, night sweats, insomnia. Every other question is literally asking about those, and people just want to know, how do I get rid of those? An interesting question is, my feet are hot. So I think people just want to know, how do I cool my body down, and how do I eventually sleep?
So a lot of it, like, you have lifestyle issues. So you can try lifestyle things like exercise relieves. So from walks to whatever it is that your body can handle. And then hot drinks in the evening, you can reduce those. And, opening windows, and the types of clothing that we wear. So, cotton is much, much better. So just invest in a few items of cotton versus 1,000 items in your wardrobe that is, synthetic products. So invest in cotton clothes, because that will cool you. They tend to cool you off. And so this is in your sleeping wear and your sheets as well, because women wake up, drenched, at times. So then the antidepressants, it's paroxetine in particular. So one can treat for a couple of months until those symptoms have gone down. But important to check that you don't have blood pressure problems. So I saw a question where a lady said, does menopause cause high blood pressure? So, and it can present similarly. People with high blood pressure also can have these hot flashes. So it's important to treat the high blood pressure as well, if you have high blood pressure, because that can present similarly. And we know that the older we go, and even some young people actually can develop blood pressure. Weight loss, very important at this time of life, and any time of life actually. So if you're overweight, invest in yourself and exercise and eating healthy. Yeah, I read somewhere also about broccoli. So the diet also is quite important. So the fruits and vegetables part of it is just, it contributes to weight loss as well. But broccoli, yeah, that was quite interesting for me. Broccoli helping to reduce hot flashes.
That's interesting. That's an interesting one. Look, Doc, I wanted to laugh, but because we depend on technology for sound, we're not in the same room. When you said open a window, I don't know, man. Because you are opening a window, but if there's somebody sleeping next to you, they just want to be in a warm place. An anecdotal story is when we did one of these Salome brand activation, there's a guy who said, guys, the windows in my house are opened, it's winter, and the electric blanket is off. Make it stop. We need the electric blanket on. Make it stop. How do I make it stop? And that's the thing, where you're just experiencing this thing in your own little body, and somebody else is not experiencing it. So I think it's quite interesting how and maybe this is why it's just the dynamic changes. Yeah, we've got some questions on here, Dr. Dunn. I think one says, evening, Boitumelo and Dr. Dunn. Does menopause also affect growing breasts? I'm 50, my breasts have increased in size. I've also missed my menses for 2 months, but now they're back again. So that's a symptom we haven't spoken about. You've spoken about weight gain, but it sounds like this weight gain is, particular to a specific area.
Yeah. So yes, breasts definitely gain weight, as a person gains weight, but breasts are particularly also influenced by hormones. So they go through different changes. If you've noticed, in the reproductive women, during different times of the cycle, so they'll feel different whether you're on your period, mid-cycle, and just before you go on a period. So that may influence. If she's still seeing her cycle, it could just be the progesterone that is, making her breast tender, feel more fuller, and all of that. But what is important is for women to continue to do their monthly breast check, and go for a mammogram as well. If you're above the age of 40, or if you felt a lump, then do consult and go for that mammogram, because if there are any changes, it could be something new. It could be cancerous. So the earlier diagnosed, the better. So I'd say, yes, hormones can have an influence, but it is also important to check that there's not something brewing in those breasts.
Ladies, pap smears and breast checks, particularly after 40, at least once a year, unless your doctor advises otherwise. Pap smear and breast exams. I beg, both public sector and private sector do them. And most medical aids pay, it's free for both once a year after 40. So please, I beg. Early detection really does save lives when it comes to that.
Yeah, I completely concur.
Yeah. Before we got onto the topic of early detection, we were talking periods. Somebody's saying that since they became perimenopausal, their periods are more painful than ever. One, is it a symptom or could there be something else? And how do they treat that?
Yeah, definitely. So, anything that is new and unknown to you, right, is worth checking out. Because if you were having periods that were not painful and then suddenly you're having periods that are painful, you have to check it out, because there are other things that cause period pain that are not necessarily related or maybe considered, the normal cycle. So you need to have a pelvic exam and see if there are no masses growing in your uterus or in any way on your pelvic organs. Yeah, so that is important. That's what I'd say. So if it's new and unknown to you, then you must rather check it out and then see if you don't have a growth or anything of the sort.
Okay. So Doc, we've got, I think, new people who signed in. Just for their benefit, I will start us at the start and then we'll go to the new questions, because we're seeing a couple new questions again, which says, what is menopause? When does it start? So I think because people keep rolling in, let's just to revisit that, and then I'll move on to some of the new questions.
All right. So menopause is literally the end of your reproductive life. So where you now stop menstruating, you stop producing, we don't produce eggs, but because we're born with a finite number of eggs, but where you stop releasing, those eggs to give you a regular cycle. So the moment it happens for a period of uninterrupted period of 12 months, so you don't have your period for 12 months, then we define that as menopause. There is a period that leads up to that menopause, and that is called the perimenopausal period, and it's characterized by irregular periods as well as symptoms of menopause that you may experience. And unfortunately, there's no reliable test that we can do. There is a hormone called follicle stimulating hormone that's made in the brain, and even that is not really reliable. So but if you are within those ages between 45 and 55, you may be experiencing menopause. And if it has stopped for 12 months, then you can, with certainty, that you have now reached your menopause. And there are other reasons, of course, that we've mentioned, so hormonal reasons, or if you've had surgery, surgical removal of your ovaries, or if you have chemo, radiation, those women may experience menopause early. Then there are other women that experience premature ovarian failure. They can be much younger than 45. Yeah, so that's the basic definition.
Doc, we've spoken about when it's supposed to start. People want to know, when does it end? At some point, it must end. the hot flashes must end. My sleep must come back. I don't know if hair comes back. I have no hair. I'm yet to experience hair coming back. Mine left me for other reasons. If it comes back, that would be brilliant. But when does it then stop?
So it varies for different women, you know, and the symptoms also vary. So it's marked, you know, by symptoms. So some women will say, you know, they experience the hot flashes in the initial stages, and then after a year or so, then, you know, it was gone. But then what follows after that is the dryness, and that just goes on and on and on and on, because everything just gets smaller. The collagen in your vagina and your vulva is just, you know, it's depleted. And so some symptoms like the hot flashes don't perpetuate, but then the other symptoms then, you know, then will be on for a bit longer. So it varies from woman to woman. And yeah, in terms of, like, you know, the treatment, we, you know, it's not suggested that they start after they had been in menopause for like after the age of 60, or, you know, you must start at least within the 5 years. So which suggests that women still experience symptoms for up to that period, so 5 to 10 years even. So yeah, it's terrible, but there is no straight answer as to when does it end. Yeah.
Did you say 10 years?
Listen.
Did you say 10 years?
Yeah, some symptoms can just carry on. But the hot flashes earlier, but the other symptoms, you know, can perpetuate.
Okay.
This we were
definitely never told. I think I just want to comment. There's somebody on the live who says they're 36 and they're experiencing some of these symptoms. And I'm going to say to them, but, you know, I'm not the doctor. Maybe the doctor will respond afterwards, is go see your gynae. So she's got uncontrollable high blood pressure. And she's had on and off periods, and she thinks she's having hot flashes. She doesn't enjoy sex anymore. So she's younger than, you know, you're younger than the age that the doctor gave. I would definitely say go see a gynae to get a proper diagnosis on that.
Yeah, I definitely agree, because there are other reasons why hormones, there are other reasons why periods stop. And, you know, it is very important, because some of them are, you know, quite serious, especially if, you know, something happening in the brain, you know, it can have serious consequences. So, because like I said, you know, we make hormones in our brains that talk to the hormones or our eggs to produce those hormones. So there could be something happening, you know, everywhere, and your doctor would be able to check head to toe, you know, to see where the problem actually lies. So yeah, very important, especially, you know, for if you're younger and you haven't had your period, you know, they must rule out, you know, all those problems, you know.
Can you stop menopause from starting? So if I'm perimenopausal, is there any magic outside of prayer to say, make it stop? No, don't laugh. Don't laugh. I mean, this is a real question that people are asking, but also, you know, some of the other questions, and the other reason why I'm asking is we got a lot of questions where people are saying, I would still like to have a child. So is there anything I can do to just stop this train from moving, whether it's a month or 10 months or 10 years? Can I do anything to stop this? From
going on by ourselves? No. So I mean, look, life can be difficult for some people. You know, if one has means, when you're younger, preferably before the age of 34, freeze your eggs, you know, because it's life is unpredictable. Maybe you want to do this with a partner, you know, have a child maybe when you get married or have a partner. But sometimes it just doesn't happen for some people, or sometimes some women want to focus on their careers before they have children. So if one has means, freeze your eggs. You can have egg aspiration. They freeze them and they store them for you. And at that point, when you're ready, because when you're younger, the eggs are healthier. Because the problem with falling pregnant later with the older eggs is that women have as we grow older, we get chronic illnesses which complicate pregnancies. And then when we get older, we also have a higher risk of abnormalities of the babies. So, and you know, other problems like stillbirths and all of that. So it gets more complicated the older we get. If eggs are frozen, or there is also an option of donor eggs, which is, I mean, you know, people look at celebrities, you know, you heard recently Janet Jackson, Naomi Campbell, I think, and whoever else, those women are well into their 50s, and, you know, then someone says they fell pregnant, but, you know, a lot of times when things like that happen, you know, donor eggs have been used. So at a later stage, your uterus, under hormonal stimulation, you know, would be able to carry, because, you know, it can do that. But in terms of the eggs that you carry, they are not of good quality the older we get. But I did hear something interesting at a talk once. I don't think it's something that's, you know, being done as yet. And they were talking of like an ovarian transplant, like, you know, why not stop menopause? Because, I mean, the effects of having no estrogen, you know, is really, you know, in terms of health and, you know, your heart health. Estrogen is so good for your heart health, for your bone health, for your mental health, for everything. And once women lose estrogen, then they become at risk of having these heart attacks, strokes, clots, and, you know, everything else. And they were talking about ovarian transplants. So, you know, they harvest ovaries, slice them into very thin slices, and they were talking about transplanting them, you know, under the skin. That I don't know if it was if it's something that's been, you know, trialed as yet, but it is futuristic. But, you know, hopefully medical science, as we evolve, this is something that we can do, because estrogen, certainly if it's endogenous, in other words, you know, made and released in your body, would be beneficial and less, you know, risky, because hormonal replacement has its own risks. And yeah, so I find it interesting. So I think in future, with if there are any scientists out there who want to do some research into this as well, I think,
look, that's an interesting concept. That's an interesting concept, but I guess also sometimes people are attached to biology, and that's why, you know, all the other options are difficult decisions to make, and it takes a while for us to understand, you know, what you were talking about, that most of these celebrities who are having children over 50 probably got egg donations, you know, because nobody actually talks about reproductive health, because it's just one of those things that I think either we're ashamed of, or it's behind closed doors, or whatever the reason is. We just don't quite express it out loud. Got an interesting question here. It says, I have Graves' disease, experience most menopause symptoms. Can Graves' disease accelerate menopause? And I'm 45.
I don't think acceleration, but, you know, unfortunately, I mean, the palpitations, the heat that is experienced from the high levels of thyroid, the hypertension risk, and the thinning hair that one can experience from thyroid disease. So some of the symptoms are you get with both menopause and the thyroid disease, but acceleration, I'm not sure. I don't know about that. I haven't read or heard about acceleration. Yeah, but I think the symptoms that she experiences, match. Yeah, and you probably exacerbate, but I'm not sure if it accelerates the process, because if you look at what it means to go through menopause is the menstrual cycle. Okay, so the ovarian cycle rather, and it relates directly to your ability of ovaries to produce estrogen.
There's a lot of other questions again about HRT, Doc. So I'm going to just get us to revisit, and it's a range of questions. It's people are either discussing specific types, or they are asking, should I go on HRT? What are the side effects? And I think somebody is saying, why does it get a bad rep? So I think let's perhaps revisit what is HRT and why HRT, while we still have a bit of time, because that question seems to be coming up. And I think maybe it's something that we didn't get into the type of detail where people can understand.
All right. So HRT is hormone replacement therapy, and it consists of estrogen preparation and progesterone. So those are the hormones that are responsible for your menstrual cycle. So in the first part of the cycle, estrogen dominates, and then it would be responsible for thickening that lining, and then also ovulation, where that egg gets released, the one that will eventually meet the sperm. And then if that doesn't happen, then progesterone would, takes over in the second part of the cycle, and that would be the secretory hormone that will eventually, lead into menstruation. So those are the two hormones. But there are other things that they are responsible for. So when we are replacing hormones, we're replacing these two hormones. So for women that have a uterus, okay, they need both, because if you have estrogen and no progesterone, then that lining that happens, the thickening of the lining that happens in the first half of the cycle, is dangerous, because it can become cancerous eventually if it's not opposed. But if you don't have a uterus, then estrogen alone would be sufficient. So the preparations that we have come with either combined, or one can take estrogen and a progesterone. But of course, these are must and must be under prescription, because when we talk about risk, your patient selection is important, because risk of, we call them thrombotic events or clotting events, and these clots can happen anywhere, whether it's in the leg, lung, heart, strokes, the risk of breast cancer, with the risk of heart disease. So those are the main, we call them cardiovascular, so heart and blood vessel risk. But your patient needs to be selected. So if you're at risk for breast cancer, for clotting and all of that, then other options of treating symptoms rather are required. So what else did they ask? So it was the risk and
it
and
was. Is there
the bad
any alternatives? Yeah, okay. The bad rep.
Yeah. So
then let's start with the bad rep, and then we'll get to the others.
Okay. So the bad rep really, back in 2002, there was a big study that was done where they had women put in two groups of it was, you know, a trial, you know, estrogen or and progesterone, right? So the risk, the negative effects that came out of that were, you know, more side effects than anticipated. But then when they followed up these women, then it was seen that it was the women that were on the hormone replacement therapy for longer. So the longer that they were on with the progesterone, then they got the risk of breast cancer, of heart risk. They were also looking at risk of colon cancer as well in that study. But mainly, you know, it shouldn't be given for longer than 5 years, and it shouldn't be given for women that have been in menopause for 10 years already. So the later you start, then the higher the risk. But you know, the uptake of hormone replacement therapy has been, you know, very low since those days, and understandably so, because, you know, people, I'm scared of having, you know, all these side effects. So I completely understand. So when women, when you look at these options, there are options of, we call it local release. So, and for a few months while you are, you know, alleviating the symptoms. So, you know, like the gels and the creams that, and the tablets that can be inserted vaginally. And there are also gels that one can put on the skin. There are rings, vaginal rings, and it releases very little estrogen in that area. So with the local, then it avoids the systemic circulation of the estrogen. And it's in small amounts, really. And, you know, for a limited time period where the symptoms are, this could really be beneficial. And you really see a difference, you know, like if women have like this thinning and, you know, tearing easily, sexual dysfunction, and you know, other symptoms of the vulva and vaginal area, it is beneficial. So it is important to, you know, talk to your doctor, let them, you know, do an exam, assess your risk of all these things, and then choose the correct one for you. So, you know, one needs to individualize these things. We need to individualize the treatment of hormone replacement therapy.
There's a lot. There is actually a lot. I never thought, you know, anything can get more complicated than just the general menses in your teens to your 30s. But this seems like a lot, and I'm still stuck on this. Could go on for 10 plus years. Just I don't think anybody was ever ready for going through this for 10 years. We've got a question which might not be a menopause question, and I think it's probably a general menstruation question, but let's get into it. We've got a little bit of time still left, mainly because when we do menstruation conversation, this comes up. And the person says, 46 years old, when I'm about to menstruate, I literally get sick, I get diarrhea, strong anxiety. One of my biggest problems is acne and itching. It gets worse before and after the menstruation period. Please advise. So the diarrhea and the sickness is something that even when we just do general menses conversation, usually comes up. And most people want to know what in the world is happening.
Yeah, unfortunately, that progesterone, you know, can cause like a lot of drama with the gastrointestinal system. You know, anxiety. Some women experience bloatedness. Some women, you know, they, even if it's not diarrhea, but they'll experience like an increased number of stools per day than they usually are used to. And then the anxiety together with irritability, mood changes, and sometimes even a low mood. Women do experience that as well. The acne, certainly just before the menses, especially in on the chin area, around the nose, that yeah, I get them here. Then I know if I start bleeding. You know, terrible. But I mean, premenstrual syndrome is a real thing. You know, it's very real, and it comes with a vast number of symptoms. And you know, one can manage, especially, you know, the mood. You can even give periodic antidepressants, the fluoxetine, you know, for that time leading up to the menses. Some they call them you know, the pimples, like anti-androgenic oral contraceptive pills. Those help a lot, especially with things like for the acne, and to reduce the symptoms. So oral contraceptive pill, once again, one must consult to see which one would work better for them. And yeah, so it is real. She's not imagining it. It certainly does exist and happens. But of course, what, you know, the consultation is important, because then, you know, you need to rule out, you know, other things that could be happening concurrently. And yeah, but it's quite real.
Doc, we have run out of time, and we haven't gone. I know. I know. And the questions are still coming. I don't know if you've got any last words, and then we can wrap up. I'll just let everybody know where maybe they can find some more answers to these questions.
Yeah, women don't have to suffer, hey. These things are inevitable. Fortunately, I mean, it doesn't happen to everyone, but for those that it happens to, can be very devastating and frustrating. But you don't have to suffer. So if you're experiencing anything that is out of the norm, you know, consult, but also, you know, read around it, talk to your friends and talk to your mothers, and, you know, come forward and seek help. The earlier, the better. I think we shouldn't get lost in our heads with all our fears, rather have someone, you know, lay it out for you, and to see what is good for you, what isn't, and all of that. So we don't have to suffer. Unfortunately, menopause is just one of those subjects that doesn't get explored often. And, you know, every single woman on this planet will go through it. And unfortunately, with some women, it comes with very detrimental symptoms. So, but you don't have to suffer. I think, you know, on your annual check, speak to your gynae. If you're experiencing problems, you know, come forward. You know, there's a lot of things that, you know, that one can do, from whether it's medication, there's non-hormonal products, there is diet that one can do, exercise, reducing stress, and other, you know, things that can really make your life better, and your spouses, and windows can close, you know, so you guys can have a good night.
Thank you so much, Dr. Dunn. I must say, because of Salome, I am having what one would call unusual conversations with their mother. You know, the other day I was like, when did you start menopause? When did, you know, this person in your family start menopause? So I think it's opening up new relationships, or new ways to run relationships. And I want to thank everybody who asked questions. I want to thank you for creating a safe space so people can ask these kind of questions openly. And I think that the key is, one, have a healthy relationship with your doctor. Find a doctor who's not going to gaslight you, who's going to hear you, understand your body, track what's happening so that when you do go and see a doctor, you've got a full list of, in August, this what happened, but actually in January, this wasn't happening. It gives your doctor enough information, but also it just empowers you. So Dr. Dunn, thank you very much. Thank you to everybody. In terms of those who still want to hear a little bit more, you can find this webinar and some answers to the questions in about a week or so on the Salome website, which is www.salome_range.co.za. We repost all the webinars and some of the questions. Because we've got your email addresses, we'll just mail you when these are up. Otherwise, this webinar was brought to you by Salome Menopause, which at the start I said is a combination herbal medicine product for the relief of menopausal complaints such as hot flushes, profuse sweating, and low moods. Again, thank you very much. And Team Salome, thank you as always.
Thank you so much for this opportunity.